Milliken. I'm the biologics director for North Texas Allergy and Asthma Associates out of Dallas. Been with the group for about 10 years now. Done a little bit of everything that involves biologics. That's my specific duty at the office. So front to finish, we have an $8 million department that I oversee for the complete revenue cycle. Today I'm speaking on navigating more than just prior authorization and some of the tools and things that we have available to us that help to do things in this space that are not just involved with prior auth, but we'll go over that as well. This activity has been planned and implemented in accordance with the accreditation and requirements and policies of the Accreditation Council for Medical Affairs for one PACS CE credit. I always like to start at the beginning. So if we're speaking to benefit verifications or investigations, I always like to run two of those, whether it be the manufacturer's hub and using their enrollment form, and then doing one internally as well. The reason for that is you want to be able to cross compare whether there's misinformation from one or the other. I personally use the manufacturer hub so they have insight into the patient, and that partnership with the manufacturer seems to be something that they really enjoy or look for. But always do your own internal benefit investigation. Usually it's going to pan out to be that they're both the same. But in this case, you'll have two call references to where you can have that call pulled if you're having some issue with the claim where they said prior authorization is not required and things of that nature. Obtain the pertinent information for the medication for the additional services that are going to be rendered, adding your injection code, your other services that are going to be along with the biologic injection and appointment. Know your patient cost share. You want to have that on your benefit investigation. That way, if we're dealing with more of like a Medicare replacement policy, whether they're going to be a 20% coinsurance or more covered than that down to their, sometimes $500 deductible, which can be affordable to the patient. So just know what that cost share looks like so that you can share that with the patient and then find out how it's going to be best for them to obtain their medication. One thing that I found value in recently is being familiar with like low income subsidy policies. These are policies that have they're commercially managed Medicare policies, but they also have a Medicaid backing that picks up the other 20%, which are comfortable for buying and billing for those policies as well, because the patient essentially is paid at 100%. So I found value in that recently. So ask the question, is this a low income subsidy policy with that Medicaid backing? One thing that's cool about that is even if you're not a contracted Medicaid provider, as long as you're contracted with that Medicare policy that's leading that partnership, it's a payable service to you for that additional 20%. Now, I will say there's times where it doesn't always go well and the 20% doesn't get paid. You can fight those claims and get the additional portion paid with that Medicaid backing. Utilize all financial assistance available, copay cards, PAP, funding from foundation programs. Always be familiar with those things that are available. Be on the lookout for something that's out of place. Obviously, you're rechecking to make sure that once you implement this patient's care, that everything as you started them for is in place and ready for their case moving forward. Authorization types and follow-up. There's pre-service and post-service reviews. In most cases, we're looking at prior authorization being the most common. All specialty medications are going to require some form of a prior authorization. With Medicare, obviously, we don't need a prior authorization. So that is the one exception. There are some commercial policies like UMR where I've seen that up to a $5,000 limit that they don't require a prior authorization. Just check and recheck that benefit verification, knowing that you do or do not have to move forward with some type of prior authorization, again, with that call reference backing. Be diligent with your documentation and making sure that your patients fit the utilization management criteria. Payer policies won't differ very much, but you want to make sure that you have everything on file that pertains to that payer for that patient. Predetermination, this is often when prior authorization is quote unquote not required. You want to ask the question, is there some kind of a predetermination that can be done? I'm not really sure why the payers differentiate, prior auth versus predetermination. They seem pretty similar to me anyway. But in most cases where prior auth is not required, a predetermination will be. And I'm thinking more around the 97 to 8% of policies will require some form of pre-service review. Advanced benefit determination. This is more often with like Blue Cross Blue Shield FEP policies. Again, if you're being told that some pre-service review is not required, go as far to ask, is an advanced benefit determination required? In some cases, payers will give you an authorization, right? And then down the road, they're going to soft audit you and ask for prepayment medical record review. More often than not, this has been United Healthcare in my experience. All documentation has to be sound from the jump, as well as for that data service with whatever it is your EMR can support as far as like templates or clickables for documentation. Authorization tips. Buy and bill prior auths are always completed through the medical benefit. Creating an account with each commercial payer's preferred EPA platform is always going to be the best turnaround time and the most efficient for you to complete these prior auths. Before submitting your PA, be sure all clinical criteria is sound and documented well. And track your PAs, whether it be in an Excel or more intuitive platform. You want to make sure that you know when your start and end dates for each patient's prior authorization is, so that you don't run into any payable issues. The authorizations are just the tip of the iceberg. Pre-service review. These are typically the more involved authorization processes where all pre-treatment documentation needs to be there, whether it be biomarkers, step 1 failed therapies, diagnostic testing, or scoring tools. I really like to use scoring tools in my practice. It helps to affirm that the patient is really in the state that we have diagnosed the patient under. Another thing that I like to do, it seems to help to just kind of like solidify my documentation, is submitting a statement of medical necessity as my cover letter. Just outlining everything that they're going to be looking for. As we know, human error is always a possibility. And so they can typically overlook some documentation that you would have submitted originally unless you've outlined it with your cover letter. This is, I have a in-house onboarding checklist for each patient. So this helps me to keep myself organized with my processes and every patient to be finished the same way, especially if it's not myself working on the case and you have multiple people touching your patient's journey. It helps to keep every case in check. So I highly recommend organizing yourself with each patient being filled out for some form of a checklist where once you've gotten to the end of that they are in fact sound and ready to start therapy. These are just some of the steps that are part of mine. Consent, onboarding starting, run the benefit investigation. Are they buy and bill eligible? Starting the prior auth. If they're carved out to SP, work that through the pharmacy benefit. Once they're approved, tracking through your platforms or your Excels. Adding the authorization information to your EHR is super important. This information will pop up in box 24, I believe it is, on the claim form, and that is the affirmation that the patient was approved, and it goes out with a claim each time. Enroll the patient in copay assistance. Add it as a secondary in your EHR so that you can submit those claims to the program. Schedule the patient for their first appointment. Once all of this has been finished, you can feel good about that patient's case and that they're ready to start therapy. Documentation for post-service review. Keeping your patients scheduled for their frequently needed appointments with their doctor based on their disease state, asthma every 6 months at the very latest. And then when they come in for those appointments, get a follow-up quality of life scoring tool. This will tell the story of the journey where the patient now has responded to therapy from the initial scoring tool to the scoring tool that we're now having them filled out. Build in the generalized templates that pertain to the specific drug and disease state, and continue prescribing within the FDA-approved criteria. Off-label dosing, things of that nature, is not something that you really want to buy and bill for. So in that case, if that's something that your doctor really does need for that patient, push them to pharmacy. Always keep up with reauthorizations for continued therapy. Again, the month before your term date is coming up, go ahead and reauth all those patients. Usually 30 days is an appropriate amount of time for the payers to allow for a reauth to be initiated. There's technology solutions that are out there for automating your processes. Definitely explore all of these options. I mean, any way that you can keep yourself more organized than an Excel spreadsheet. I mean, we all love our spreadsheets. I know I do. But there are more automated systems that are coming to market. So be diligent, get in front of those people, have the conversations, and see what it is that can offer you as a benefit. Your portals, your supplemental platforms, EHR, EPA platforms, specialty pharmacy portals. I know that it becomes a lot because you have so many different browsers that you have to keep track of. Find the process that's best for you, whether it be start by paper, portal, whatever it may be. I'm more of a tech guy. I like to keep things as streamlined as possible. So there are some, every manufacturer offers a lot of these streamlined type processes. One thing I do like to highlight as far as how you set up your copay assistance in your system, there's a couple of different ways. You can run it on the card terminal. You can manually submit the claims to the program and get ACH payments to your bank account. Or there's EDI, electronic data interface, where it goes out as if it's a secondary payer. Be cautious of that because these payers are applying the accumulators to what they can see on the claims as they go out. So if at all possible, stay away from EDI, even though it does sound like a really good idea, makes life easy. I've seen that actually happen with another biologic director that's here today. She asked me, hey, what's going on? I said, are you EDI? And sure enough, that was the case. So I kind of went really, really fast, so I apologize about that.